This is the topic what we are trying to go through. Everyone is already having the slides. So now imagine you are there in the emergency room. You get a 75-year-old female patient. Okay, she does have some risk factors. Okay, the risk factors are diabetes, hypertension is there, and she says, just with like till 60 minutes ago she was doing all fine, everything was fine, she was watching her television, and then all of a sudden she had a chest pain. Okay, and it's like typical in the sense, central crushing, it is relating also to her left shoulder as well, and she's having a little bit of sweating and all, so it's like, let's not divert about this and all. So then what had happened is, earlier as well, just 3 months before, she had been to her physician, local physician. Okay, they did a ECG which was normal, but now the question comes is, patient comes to you. Okay, so you try to see on those different parameters what we are supposed to access. So you saw the patient is conscious, oriented well, the heart rate is on the higher side, around 120 beats per minute. So it should ring a bell. Okay, with a chest pain, heart rate is slightly on the higher side. Then you again check the blood pressure as well. So blood pressure is again 180 by 110 millimeters of mercury. Is it normal or abnormal? Okay, good. You auscultate it as well. Auscultations can be a little bit tough at this stage. I understand. I was also not so good. So you saw, okay, it's not so big abnormality. You try to auscultate for the chest as well. So you didn't see any abnormal sounds. It was mostly normal, okay? Now comes the ECG. So if you'll go in the slide 5, can you see the ECG? The next one, yes. So this is the ECG with which the patient is there in front of you. So what do you think? What is happening to the lady? So how do we report a ECG? What are the steps for that? Awesome. Awesome. Okay. So when you see this ECG, what do you say?
It looks like it's a regular rate.
Wonderful. This is regular. I agree with you. Okay. Regular. And what else? So you have the slide as well.
75,
Yeah.
88 beats per minute or so.
Okay. 88 beats.
75.
No. Okay, I I don't want to divert you again to those things. In simple basis, so there are different rules. There are simple rules as well. Right. So it is more than 4 boxes, isn't it? So it is going to be less than 75 beats per minute, or is it going to be more than 75 beats per minute? Right. So approximately it should be, so if we try to be precise, 1, 2, 3, 4, like nearly almost 5 boxes. I would say small, 1 box is short of that. Yeah, exactly. So she's almost there, in fact. That's good.
I use the calculator.
Oh.
I can't actually work out 325.
No, the best way, of course, if you want as well, use those zoom in. You can always count those boxes as well. You know it, multiply a little bit of, calculator is the best, to be precise, in fact. So that's one of the reasons as well. Never depend upon the explanation which is there on those machines. Humans are more smart, okay? Always remember that. Okay, trust yourself. Okay, always use those, whatever interpretation is going to be there, a little bit of indication, but not always depend upon that. As I said, it always go through what all things and all, and as so how to systematically describe a ECG, rate, rhythm, axis, then comes the abnormalities, then you can start going for individual things like the P wave. Are you able to see those P waves or not? How about the QRS? Then comes those segments. Okay, the PR segment, is there any abnormality? Then the ST segment, is there any abnormality? Do you see something big abnormality? Other things as well. This is how you continue about that. So for example, in this, let's try to have a look. Are we able to see the P waves in this? So what are the leads? Now, okay, I'm again have to divert again from my topic. So what are the leads you try to see for if you want to see for the P waves?
2.
Good. And there are various of them. 2 is one of the best. Now,
1.
V1, V1 and 2, lead 2 is in fact they're the best. So if you try to see in the lead 2 as well,
Okay.
are you able to see P waves or not?
Yeah.
Yes. So this is a sinus beat or not a sinus beat?
Sinus.
Wonderful. See, you all are so intelligent. Okay, so we see a P, there's a QRS, there's a T wave as well. So definitely this is a sinus rhythm. Now we know the rate as well, okay? So there's no bradycardia, it's not a tachycardia, okay? This is in good rhythm, in fact. Okay, then what happens? Yeah, wonderful. So how's the axis? Okay, I'll share some tricks as well with you all. Because those tricks were very helpful for me, like when I was doing my medicine. But remember always, you should try to use that formula. That is always the best. Why I'm trying to tell you? Yeah. So they are the best ways, but what happens is whenever you have to take some quick decisions, especially in the earlier times, you can always use those tips and tricks. And always remember, tricks, they always also have its limitation. They should be used only till that time. I would say till the time you get those rules in your permanent memory. That's what I mean. So simple rule is like this is you try to see in the axis in lead 1, lead 2, okay? So what are the things? It will be either normal, left axis deviation, right axis deviation, or exactly, or northwest it is called as. So lead 1 and 2, for normal to call it as, it will be exactly. So this is what it will be. And for left axis deviation, one will be positive. Okay, and yeah, it will be positive. But what happens is in the right axis, it will be opposite. Okay, so here lead 2 will be positive. And here the other one, of course, will be negative. So just looking at these two leads, you will be able to point it out. But as I had said it, always to be more precise, you remember the normal formula, right? How to take, so for example, lead 1 is how much is the deflection, lead AVF, how much is the deflection. But it can always take time, and in the initial few years, it can be a little bit difficult. So this is just a short and good trick, okay? And similarly, northwest. Northwest, what is going to happen is both of them is going to be right. So you will always, and that is what. So northwest, when do you see that? If you want as well, you can come over here. Yeah, are you sure? Okay.
Like dextrocardia or something.
No. Northwest, if you see that axis, your eyes should be alert.
Ectopic.
Ectopic, yes. VTs. If you see a northwest axis, boom, time for action. It's like that. Okay? So now you guys will not forget, right? So, okay.
When you say VT?
Yeah, northwest is mostly in terms of VT, ventricular tachycardia. So if you come across a northwest axis, be alert.
As in, it means they will go into VT or they are
having VT.
Okay.
And see, medicine is always like your diagnosis should never be dependent always on the one thing. It should always be supported by other evidences as well. So for example, when you call it as VT, when do you call it as VT? I'm so sorry, I'm diverting again from the topic because I want you all to have a good comprehensive overlook as well. When do we call it as VT? Simple.
Absence of P and broad QRS complex with tachycardia.
Please use the chat box. There are some students as well, as I had said it. Okay. Please use the chat box. So when do we call it as VT?
Yeah, wide QRS complex.
So simple things. Again, break the words. Ventricular tachycardia. So the ECG, when you will look, it will be ventricular in origin. How do you say atrial or ventricular origin? I'm getting away again. Where am I supposed to go? I'm going the other side. So in the last session where I had taken it from some of the students, I had explained that if there is supraventricular origin, most of the times they are narrow QRS. But from the ventricle, when they have an origin, most commonly broad QRS, right? And there will be a tachycardia, right? So tachycardia is going to be, the heart rate is going to be 80, more than 100. Okay. Now, coming back to our ECG. We have diverted enough to get a good number of basics. How do you differentiate a left bundle branch block and a right bundle branch block? So seeing this ECG, even this, there's a trick. How much are you all aware of this? Okay? You all aware? Okay, very smart people. So always what happens is in this, you try to look in the V1. So if you look over here, it's a negative deflection, right? In the ECG, if you all will look. And in V6 is positive. So which definition will it fit? Exactly. So this is a wonderful. See, you're intelligent. Okay. However, I'm not going to show that example because that is again out of topic. But marrow is V1 will be positive. Okay. V6 may or may not. So the key is always is try to see on the V1. Okay, that's what is always the key. Okay, so now we are aware. This is a sinus rhythm, left bundle branch block. Normal axis is there, in fact, as well. There are some subtle changes as well. I don't want to confuse you guys right now at least. Okay, so you know what is called as the intraventricular conduction defects and all. I'm just trying to introduce these topics to you that it will be there in your mind, and whenever you're trying to read more and more, if you'll come across, you'll be able to understand. Okay, so now further, what else do we notice? So the QRS is wide, isn't it? QRS is normal or yes. So let's go to P now. We are aware. Okay, it seems normal. QRS seems to be slightly bit broad, right? You can always put those calipers and have a look as well. Now coming to the ST segment or the T waves. It seems a little bit, as he already pointed it out, wonderful. Seems like ST elevation is there, isn't it? But if you will try to have a look over here, something is called as concordance pattern. Something else is called as discordance pattern. Anyone is aware of that concept? Okay, so if you will go into the next ECG, I'm going to give you one more. This is a practical ECG.
It's concordance where they're all sort of raised in one region.
Wonderful. Exactly. Are they in agreement with each other or not? Are they pointing in one direction or not? So for example, this ECG, if you look carefully, it's the date is also written. In fact, so this had happened like 22nd of January. So 22nd of January, I was on call. I received a call from the emergency department over here in Manchester. They said, it's a VT. Please come over here. We want to shock this patient. I said, please, can you send me the ECG? I went through the ECG. I said, no, there's no shocking. So this is going to be the tricky case for which I am going to ask for an explanation at the end of it, at the end of our session. So in the meantime, I'll keep on giving you those inputs and all. Okay, at the end, I will expect an answer. So in this as well, what do you see? Just now, some definitions and all. And I asked it, and I did something for the patient. I did something, okay? Some magic. Go to the next ECG, which you can see, right? So the white QRS tachycardia, which was going on over here, we start seeing those sinus beats, right? We can start seeing those P waves there, QRS, T waves. I did some magic. What was done? And I would say a big hint for that is it's a physical maneuver. Good. I actually did was a Valsalva maneuver. Are you aware? Okay, let me make it difficult. Modified Valsalva. Are you all aware for that? You should read about it. Okay, now let me get back to our topic, okay? Myocardial infarction. So what I mean is, it is important to do those maneuvers as well. But there are rules for that. If you should try to see about the hemodynamic stability of the patient as well. If the patient is hemodynamically unstable, never hesitate to give a shock. Okay? Because the patient is always the key. We are there for that. Rest everything else can wait. Okay? But always also be sure you should not give unnecessary shocks. And that's the reason we are trying to have a better understanding of the ECG and the fundamentals. So that's why it is important. So now in this ECG, as I was already telling you, so what is happening is everything has already been written, in fact, over here. So QRS definitely is wider. Okay, we do see there are no Q waves. So one thing is there, how to say about those Q waves? A lot of times it can be difficult to say. For example, especially in the lead V1. If you look in the V1, if you zoom in, no, if at any moment, if you notice, even if slightly tiny bit of positive deflection, never hesitate to say it as a R wave. Always say it as a R wave. This is not a Q wave. So there is a small, very tiny R wave is there in the V wave. So this is what is happening is there is no Q wave. So what is Q wave indicative of?
The start of ventricular depolarization.
Q wave, I'm asking. Okay, you're almost there in that direction. So, but what is the definition of a pathological Q wave? Now, let me try to make it easier and clearer.
Especially deep or too wide.
Yes, how deep, how wide? You're there. Oh, you're almost there.
2 small squares deep.
So, depth-wise, at least if it is at least 1 millimeter. If it is 1 millimeter, you should be considerate, I would say. You should be considering that, what is happening over there, in fact. Okay. And then, as I was telling you, so what is happening is, V1 to V3, how is the polarity of the QRS? Is it positive or negative? V1 to V3, is it positive or negative, the QRS? Negative, isn't it? And when you look at the ST segment, or the T wave, is it positive or negative? Positive, right. So what is happening is QRS is negative, but the T wave is positive in V1 to V3. Now what is happening in V4 to V6? Let's go through. For example, like V5, V6. QRS is positive or negative? Positive, right? And what is the T wave? Yeah, I can agree. Like V5 is more of a positive. V6 is not really positive. It's more like a bifid. Okay? Isn't it? And in 1 in AVL, for example, the T wave and the ST segment as well, there's depression, isn't it? So there's a T wave inversion. If there is any confusion about any point, let me know. So about the bundle branch block, it's already clear what is right bundle branch block, what is left bundle branch block, right? Never forget. As I said, always remember those tips and tricks. It should be there in your brain somewhere. But if someone asks, why do you think it is a right bundle branch block? So always say it like that. Oh, in the lead one, I can see there's R, S, R dash deflection. Okay, not marrow, blah, blah. It's there only for you to be able to help you, okay, to have that clear concept.
In number 4, you said discordant ST segment T wave changes in V1 and V3, right?
Right.
Could you explain that a bit more?
That's what we are going to speak about it in those next ECGs. Okay, so now we are completely sure about those bundle branch block concept as well. So we are knowing the left bundle branch block, right bundle branch block, and the criteria as well. So the question which we already spoke about is why left bundle branch block? Because the left bundle branch block, what is happening is the left bundle. So it is the blockage of electrical conduction in the left bundle, right? Isn't it? So there are different causes. So what can be those different causes? There's an aortic valve, right? Isn't it? There's an aortic valve on the left side. And on the right side, which is the valve corresponding to the aortic valve? I hear only 2 people, and I can see there are like 7 of us. Yeah, pulmonary valve. So what is that procedure which is called as switch? So for example, you take an aortic valve, put it into the pulmonary into the aortic valve. Exactly.
What's it called? Ross.
It was named after Sir Ronald Ross. And where did he work? Anyone is aware? At Guy's Hospital, London. So he used to do, And what was the logic was same thing, like because aortic valve is across the high pressure, so that's why the sclerotic changes, old changes and all, it happens. And so that was the logic. Anyways, now coming back to our topic. Of course, myocardial infarction tends to happen if there is extensive coronary artery disease as well, and if there's associated hypertension, and also if there is a disease of the electrical conduction system. Okay, so those problems can happen, isn't it? So the problem always happens is a lot of times due to those bundle branch block diagnosing, as I had already been telling, that it can be a bit difficult to diagnose. There's a bundle branch block, so this itself will be causing some ST segment changes which will be coming out. So how to say, in fact, so they did a study, as I was telling you, whatever, if we are trying to tell, there's a evidence for that. And if someone is telling something, there's no evidence, those things, they don't have a scope. They should not be practiced in medicine. Okay? So what had happened is, they tried to see in the National Registry of Myocardial Infarction. So they could see it like this. Of course, left bundle branch block is more common compared to the right bundle branch block. Now coming to our main question, what are the changes which is happening over there? So what happens is, as I was telling you, this entity, which is the left bundle branch block with myocardial infarction, it is more common in two kind of people. So if someone is having multiple comorbid conditions, alert sign. Okay, I should anticipate this. These are the things which I should look out for. There should be a differential diagnosis as well. And if someone is in old age, okay, in the high age group as well, we should be careful for that. And as I had already said it as well, is it should be a new left bundle branch block. So a lot of times you may come across that someone is not having a recording of those old bundle branch block. So what you try to do is, if you're not, you should give them, you should try to verify the diagnosis of myocardial infarction on the basis of other parameters as well. So ECG is not always the only parameter on which you think that someone is having myocardial infarction. Clinical assessments, imaging, those blood tests, and everything you should try to use. That's why always in medicine, never give your diagnosis by one thing. Okay, if by one thing, yes, you can always include that in the differential diagnosis. But to confirm it or tell it as a diagnosis, this is the thing. There, you need to have multiple evidences as well. Similarly, even for the myocardial infarction as well. So what happens is, why the left bundle branch block? Why we are thinking in myocardial infarction? So we have such a smart people and all. So someone had already said it as well. So what happens is, it can also suggest the occlusion of the left anterior descending artery, LAD, what is called as, and due to which what is happening is, a lot of area of the left ventricle, which is the biggest area, okay, is already into ischemia. Ischemia is there's an infarct, there's a problem which is going on, and that's where we should try to, in fact. And the problem, a lot of times, what happens is, due to the transport and all, yeah, PCI is definitely the best. So PCI or some kind of therapy, anti-ischemic therapy should be done, in fact. But a lot of times, due to confusion in the diagnosis, someone is really not sure that something is happening out. That's where the problem starts to happen. So that's why we are trying to do. So they did several studies as well. So they tried to bring together all those ECGs and all. So they said it was up to, in multiple studies, they found the incidence of left bundle branch block with myocardial infarction ranging from like 13% to almost up to 32%. 32% is pretty significant. Okay, so there has been a varying range, but it's a good still percentage because it's an emergency. In emergency, if you're able to see even in 1/6 or 1/3 of the patient, I would say, like, I would agree like a figure of 15%, or maybe at the most is like 20%. 32% is too high, but yeah, some people have published. We cannot say no to those people and all. So this is what had happened, and then what happens is that, yeah, not all those patients who even they come to the emergency room, they were seen by people as well, those physicians, and they were not all of them have been receiving either a fibrinolytic therapy, otherwise a PCI as well. Because what had happened is once they tried to do a biochemical evidence is
Components,
wonderful.
D-dimers.
D-dimer.
I mean, not for this, but
Okay, if you're thinking about some other differential, something else as well, okay? Pulmonary embolism and all those things, okay. So those things are, you have to also try to have a look as well. So a lot of times it may not be supported. Are you aware of something called as MINOCA? Minoca. Think I can already, she's thinking. Something
Myocardial infarction, with new onset,
normal.
normal.
Yeah? NOCA. You're almost there.
Cardiac.
Almost there. Minoca stands for myocardial infarction in non-obstructive coronary arteries. So there is a percentage of people where that can also happen. So in the you did the angio, normal. There's no stenosis, no obstruction and all. So that is one of the other things as well. See, we all should also understand angiography is not the foolproof test. So something is called a microvascular angina. So there are a lot of those vessels as well, those fibers, if you will remember those anatomy days, where the contrast cannot go and you will not be able to visualize. Okay?
you get this in anomalous coronary arteries as well, right?
Yeah. There are a lot of different other abnormalities. But right now at this stage, always remember what is normal, what is not normal. Being a medical student, that is what the common things at least you should try to think. White QRS tachycardia, unless and until proven wise, treat them as ventricular tachycardia, always. Yes, but start thinking, if possibly, if you can think of the differential diagnosis, which I already said it. What the bundle branch block, is it a SVT with aberrancy and all those things. Okay. So this is one of the first papers as well, which they tried to see the left bundle branch blocks with myocardial infarction. So that is where they tried to see as well, and they found out the therapy to be able to help those patients has not been given. So that is where it comes that we all need to be aware of this entity as well to be able to help those patients, so that we are doing justice to those patients as well. Okay.
Can I just ask, as long as the patient's not at risk of bleeding, is it not just safer to thrombolyze them anyway?
That's a very good question. So what happens is it depends upon what is the context. So for example, in US, otherwise so some of those big countries and all as well, if it is going to take a lot of time as well to shift the patient to the nearest center where the patient can be managed well. I have worked in India as well. I worked in US as well. So in Germany as well, this is a true thing. So the paramedics will be trained to give a fibrinolytic therapy. So because if the nearest PCI center where they can do a PCI, percutaneous intervention to help that salvage the heart and all. If it is going to take a lot of time, they can. In US, they do it, in fact. So if someone is a periphery and all, US as well, it's a pretty huge country, like even in India as well. So if there's no PCI available and all, and it has good rates as well, but it does have its own side effects. So one should always remember in one thing in medicine is whatever you're trying to do, always be sure of the contraindications and the indications. If you're sure for that, that's good. Because you're aware in US what happens is if anything goes wrong.
So, I mean, but if a patient doesn't have risks of like bleeding or any predisposition to like a terrible bleed, why would you not just thrombolyze them?
So, okay, there are a lot of studies which has been going on as well. So what happens, there has been a concept called as golden hour rule. So in golden hour rule, so what happens is even if you do a PCI, okay, or even if you do a fibrinolysis, not thrombolysis, thrombolysis is not the right word.
Okay.
Why? Because those blockages, they consist of fibrins. They do not contain thrombus. They are fibrins. And this is the reason what you try to do is, what kind of agents are you trying to give? That's a very, a really over smart response. So I meant, okay, please. Yeah, you said something?
Oh, I said alteplase.
Wonderful. Alteplase. What are the other options? Alteplase, retiplase, those urokinase, those old generation was streptokinase as well, right? So they in the golden period. But what happens is they do have those different risk factors like hypersensitivity, bleeding risk as well, and they are not always successful. You know, the TIMI-3 flow, what we call it as thrombolysis and myocardial infarction 3, that that the stenosis, the occlusion should be gone away. It's not always achievable. It is unpredictable, and that is one of the reasons. If PCI is available, they try to see for that. But in the golden hour period, yes, both of them are pretty equally effective. In fact, yeah. So that is where those criteria. Did you understand? Do you have any questions?
No, I don't.
Anyone? Any questions so far? Okay. So we already spoke about that is where, on the basis of these studies, they were able to come criteria, a set of criteria, what is called as the Sgarbossa criteria. So what is that Sgarbossa criteria? So they try to see, yeah, this was again observed in like nearly 26,000 North American patients, in which it was confirmed like, okay, it is a myocardial infarction. There's left bundle branch block. So what could they see? They try to propose a scoring criteria, in fact. Okay. So on the scoring criteria, what they saw was 3 things. So on the basis of 3 things, what are those? So you can give them score of either 5, either 3, otherwise 2. You give them a highest score of 5 when there's ST elevation of more than 1 millimeter in the leads with a positive QRS complex. Now, do you remember? Can we recall those ECG which we had seen that patient? So there was some of those leads in which there was ST elevation leads, right, with positive QRS, okay, especially in the V5, V6, okay, and if it is there, I'm going to show you some more examples as well for this. Don't worry. If it is there, give them a score of 5. Unfortunately, this is not a match of cricket, right? How many of you are interested in cricket? Only one?
I'm just trying to figure out how it all works because it's very complicated.
Oh, yes. So they don't have those easy scores, 4 or 6. Exactly. So over here, they have like 5, 3, and 2. So 5, now you're aware, comes as 3. So now for 3, what happens is, if there is ST depression of more than 1 mm, okay, in V1 to V3, then you give them score of 3, okay. Then comes, so for example, the least score, which is of 2 scores. So this is also like you're trying to give them scoring, you're trying to do. If there is ST elevation of 5 millimeters, but in negative QRS, so this is what is called as a discordance. I'm going to give you some more examples as well. So what happens is, if you get a score of more than 3, so what is going to happen is 90% of such patients.
Hi, sorry to interrupt. We used to do the device MDT in here at 12. The education, are you nearly finished or?
I think it was now teaching.
Yeah. Okay.
If not, the education room is booked out for medical students.
Yeah. Okay, then we can go over there.
Do you want me to go and lock it for you?
Oh, yeah, please.
Well, we need all PCs in here to do the MDT.
Okay.
I'll lock the room for you. Do you know where it is?
Oh, yeah, sure. Yeah. We'll go over there. Okay. Please. Okay. Let's go. Sorry, no, it's okay. It's what happened yesterday only. I was set to, for this session actually. Never mind. Thank you. Come on with me. Yes. Please be careful. Okay, please be careful for this. Thank you so much. Thank you. Oh yes, this is good. This is good. Wonderful. So now, I hope you're aware of the Sgarbossa criteria. So we did already revise about it.
Yeah.
Please be comfortable. Okay. So now coming back to the Sgarbossa criteria. Okay, so yeah, this is a small reference, but so that is what it is. So the main important thing is those ST deflections, and on the basis of that, the scoring, what we are able to do over there. Okay, so that is why it is important. So in this slide, we can see very clearly how you do the scoring: 5, 3, 2. Okay. So you give the maximum score when there's concordance with the QRS. Remember it like that. Concordance with the QRS, okay, you give a score of 5. Even if, 1 millimeter as well. Score of 3 when there is depression, okay? And when there's discordance with the QRS, you will give a score of 2, okay? Now, examples. Examples are always the best thing. This is what is always important for me, is to go through those examples. So you can see some examples in this. So what is happening is, as I was telling you, you see the QRS and the T wave, okay? Everyone can see it, right? Yes, wonderful. So in sum, what is happening is, the QRS is positive, T wave is negative. So this will be, exactly. And there are some examples. So for example, like this one. So what is happening is, the majority of there's negative deflection. So for example, in this negative deflection, but this is positive, right? So this will be an example of discordance. All is simple thing. Everything is positive, concordance. Everything is negative, concordance. But something is positive, something is negative. On the opposite side, discordance. The word itself explains for that. So, for example, for the left bundle branch block in the V1, if we all will remember the criteria which we all had shared, okay? So what is happening is, in the V1, there will be a negative deflection, right? With wide QRS, which will be more diagnostic. Then what is happening is, you start seeing about those, what is called as secondary ST segment changes, which is happening. So what do you notice is, for example, there's more of a negative deflection, right, in the V1. However, the T wave, or the ST segment changes, it is more of a positive or negative? It is positive. So this is concordance or discordance? Opposite directions, right? So this is discordance, isn't it? So then, for example, in this ECG, for example, what is happening? It is more of a negative deflection, right? The QRS is more negative, and the ST segment, if we try to have a look over here, is again negative as well. So down, up, or down, down. So both are down, down, right? So you will call it as concordance. And the first example, which is there on the left side of the screen, is down and up. So QRS is down, but the ST segment is up. So this will be called as discordance, isn't it? It's as simple as that. Now coming to the V6. So as I was telling you, whenever we are trying to comment about those bundle branch blocks, the important things for us is to not just to look in the V1, but also have a look in the V6 as well. So in the V6, same thing. So it's up and down, isn't it? So up and down will be discordance. And the second example is up, up. So up, up means concordance. So this is again another practical example. How will you be able to see whenever you have a ECG? How do you notice? Okay, so the points, how do you do for the scoring, in fact. And Yeah, please.
In one of the earlier slides, it says discordance equals good equals secondary, and then concordance equals bad equals primary. What do you mean by secondary and primary?
Okay, so what happens is whenever there is a concordance, so what, see, because whenever you get a score of 5, higher is the score, it may be associated with more adverse prognosis. So you should expose them for percutaneous intervention as soon as possible. Okay, and as I had said it, minimum score is 3. If it is less than 3, you know, you can do a delay or all those things as well. It's not a problem. But more than 3, immediately you must consider a fibrinolytic therapy, the PCI, whichever is an approach. And higher is the score, for example, in this concordance, which I am telling. So you get it like minimum will be 5. So you must immediately, a primary criteria, in fact, primary PCI criteria you can think of. Okay? So now some more practical examples. If you look in the immediate ECG right now, so what is happening over here? So sinus rhythm, right? There's a P wave, QRS, ST segments as well. We can see it over here. And the heart rate is less than 3 boxes. So definitely tachycardia. This is sinus tachycardia. Axis-wise, normal. So there's some ST segment changes. There's ST elevation, for example, in V5, V6 and lead 2. Okay? There's some ST depression in lead V2, isn't it? So always go through all those leads, in fact. That's really important. What is happening in all the different leads as well. And now what do you notice in V5, V6 and lead 2? There is ST elevation. And the ST elevation is how many millimeters approximately? Yeah, right. So our criteria was if it is more than 1, does it fulfill or not? Exactly. Okay. So it does fulfill that criteria. So definitely this patient is into problem. So what is happening into this ECG now? For example, the second ECG. So as we can see it again, sinus rhythm, sinus tachycardia is going on. Okay, wide QRS, there's left bundle branch block, right? So already the answer is already given over there. So go for the answers, I would say. Be honest to yourself. Right now, I'm there to help you guys, okay, everyone. So that's why I'm able to help you. But later on, when the patient is going to be there in front of you, you will be on your own. You will have to take decisions. So that's why I always try to have a systematic approach, and it will be always be the best help for you. So in this as well, what do you notice? All those wide QRS tachycardias, sinus tachycardia. Then you notice like there's ST elevations, of course, okay. And then, the answer is also given, in fact. So what happens is not just the concordance pattern is there. For example, in V5, V6, in fact, there's also a discordance pattern. Discordance pattern, where is it? In V2 and V3. Why? Because there is ST segment elevation of more than? Right. So, and this is one of the reasons as well we shared the presentation. So you can always zoom in. And whenever in doubt, this is the benefit of the digital ECGs if you have. So you can always zoom in, take your calipers, try to put it up. You can see those markings, how well is it, how much regular, irregular, like that. So they're trying to see as well recently, is it good enough? So that is why I call as if anyone is telling something, any theorem has been proposed, what about the validation? Is it valid? Is it good? Like that. So they try to see as well. It seems there are 2 things of any tests. Something is called as specificity. Something is called as sensitivity. So specificity is about? No. Truly positive. Okay, and sensitivity is? Exactly. Okay, so for example, is the person having really that problem? So that is specificity. To call it as, for example, if you do a CT coronary angiography. So CT coronary angiography has a sensitivity or specificity? No. Sensitivity. So if you want to rule out someone doesn't have a coronary artery disease, it is one of the best tests. If you want to rule out someone as having a really coronary artery disease or some problem in which you must intervene, which test has one of the maximum specificity? Maximum. There's another test as well which is almost close. Gosh, why you keep on going D-dimer, CTPA? Is it your favorite topic?
I just remember that.
Exactly, that's about pulmonary embolism.
Yeah, I just remember that.
Okay, so what happens is some of the best tests if you want to see if someone is truly positive for myocardial ischemia and those problems is myocardial perfusion scan. Myocardial perfusion scan. Then comes as PET scan, PET stress test as well. Then after that comes as like on a gross basis dobutamine stress echo. Then comes is ergometry, treadmill stress test, like that. Okay. So this is really good to rule in. So yes, someone is having a myocardial infarction. Someone is having a problem. You should do something. So it is a good for. It has a very good margin of specificity, in fact. So they have been also trying to do a lot of several studies as well, trying to increase the sensitivity. So sensitivity, what they did was, there was a scientist called as Wackers. They tried to see for this and also try to add up another imaging studies as well, in which they saw with if you not just do the serial ECGs, but also you start commenting about the ST segment elevation. Okay, so you can add more, you can make it more sensitive. If you come across the abnormal Q wave as well, you can further increase the sensitivity by 31%. So these are some of those criteria, but I can understand it is not so easy. There's some fancy names as well. Something is called as Cabrera sign. And Cabrera sign, it's not a really good sign as well, not the best sign if you want to, someone wants to comment about it. But so that's why it is like 27% sensitivity and only like 47% if you really want to comment about if it is really a MI as well. Has anyone come across these signs? Chapman sign, Cabrera sign.
Sorry, maybe it's because of the sensitivity.
Good. Good. So these are again signs of myocardial infarction and when there is an associated left bundle branch block. Okay. So for the sake of, just to keep all these things as well in the mind, but they are not the best tests, as I already showed you. The sensitivity is not very high. The specificity is also not very high. But to be aware, so what happens is, if you all will remember, there's a P wave, there's a QRS wave. So the QRS wave has an ascending limb and has a descending limb as well. So if in the ascending limb, the limb of the QRS, which is going up, okay, if there's a S wave, believe me, these signs are very notorious and all. So if you're trying to have a look, those S waves, there's notching and all in the QRS, you will come across a lot of those signs, even for VTs and even for this myocardial infarction as well. So in the ascending limb of the S wave, if there's a prominent notch, but how will you call it as a significant notch? If it is more than 0.5 milliseconds. Okay? If you come across that, that is what is Cabrera sign. However, the Chapman sign is in the ascending limb of the R wave, which you can see one of the examples over here. If you come across this, if these senses are going to be there, you can have a specificity. Yes, if someone is having an acute changes like this, 90% of the times, yes, exactly, it will be truly positive. So let's try to show you a practical example what is happening. So if you look across this ECG, which is there, so this is again a left bundle branch block ECG, and then when you will be looking before MI and after MI. So what do you notice? In the ascending limb of the S wave, there's a notching which is coming up. And the notching is more than 0.5 milliseconds. Oh, sorry, 0.05 seconds actually. Okay, so that is where, especially over here, you can see it in the V3 lead over here. So what was the Chapman sign? If you all will remember, it was in the notching in the ascending limb. So on an overall basis, whenever you see those notchings as well, you have to start thinking there has been a MI, myocardial infarction as well.
So that's in the past, not acute, not like immediately, right?
Immediately as well, you can think of. So, but you should be always the thing is, you should be able to, if possible, if you have an older ECG for comparison. You know, as I said, you never depend upon one sign or symptom to make your diagnosis. Always try to have a more and more supportive evidence as well. So that's always more important. ECG, okay, fine. What about those biochemical parameters? What about the signs as well? Could you see some symptoms as well, like those things? So you mix it up, everything together, and then and the risk factors as well. Okay. So as I was telling you, if you'll put them all together, you can reach a specificity of almost 90%. 90% is really good value if you're thinking about diagnosis for sure. But sensitivity is pretty low. Okay? So to call someone as truly negative, it may not be the best criteria. But yes, if you come across, with these changes, yes, you should start having the suspicion, in fact. But medicine is the field of exceptions. Higher you will go in your field, there will be more and more exceptions you will keep on coming across. Believe me, this is how it is. So, yeah, on most of the time, so 90% yes, but 10% of the times it may not be happening. So now they have also been trying to see that how to even make it more better. So that is what is called as the occult MI study. Occult MI study was optimal cardiovascular diagnostic evaluation enabling faster treatment of myocardial infarction. So in that, what they did was they proposed a newer algorithm, what is called as a man's, it sounds a bit gender biased, but okay, Rubin and Mann's algorithm, in fact. So this is also similar. If you will try to have a look, it is almost sounding a bit similar to the Sgarbossa as well. But what happens is they try to simplify the Sgarbossa. So how did they try to simplify it? Because that scoring which was there, they tried to say, okay, we don't believe in the concordancy, discordancy and all. Okay, these are outdated concepts and all. We don't, okay, scoring concept also can be a little bit more difficult to follow and implement as well, because we all are humans, okay? We all can't remember everything, in fact. So we can always refer to those things, what is happening over there and all. So that's why they said it, they try to remove those factors as well. However, even now, Sgarbossa criteria is a widely applicable. It is a standard criteria and it is acceptable, in fact. Okay, so being in UK, one of the key things is if you are practicing medicine in UK, I'm sure someone will be having their plans to practice it in Australia, maybe Canada, or US or anywhere as well. But in UK, we follow is NICE guidelines. Okay, that's what is more important, and they all, I think anywhere as well in the world as well, if you'll practice, Sgarbossa criteria is going to be valid enough. So that is what is one of the key messages is. I hope you all understood it. If there's a new onset left bundle branch block, alert. Fibrinolytic therapy, stop calling it as thrombolytic therapy, because this is where, if we have a misnomer, confusions will start to happen and all. Because we will be calling, thrombolysis, thrombolytic agents. No, they are fibrinolytic agents, because those fibrins are the ones which come together, they occlude the vessel, and that's why we are trying to give as a fibrinolytic therapy in terms of those agents which we spoke about. But that's not today's topic. Our today's topic is the things which we are discussing. And the Sgarbossa criteria, as I already said it, it's a wonderful, very highly specific, but not so sensitive. So that's what we should always keep in mind as well. And whenever there is a high-risk patient, and as I had already said it, those two subsets of patients which we all are supposed to be careful for is
people with comorbidities and people who are older.
Wonderful. I'm so glad I listened. Yeah. Okay, someone is able to recall all those things. Good. So this is there, and yes, there's a modified version of Sgarbossa's criteria as well, in which I think they try to do away with the scoring thing, and also with those discordance as well, to make it more simple. But Sgarbossa criteria, as I said it, whenever in practice, if you come across this, always apply that. And that's what, because as I said it is important because it's always times of emergency. In times of emergency, in the sense, uh, we should be able to help those people. And if you don't make a quick decision, time is muscle. You all have heard about this? Because further you're going to delay the decision making and all those things, every minute counts. So that's the reason, and that's the other reason as well. I shared those tips and tricks. Use them. Keep it in your mind, okay? But the best thing is, of course, going through R dash pattern. But though there are some shortcuts as well to be able to use that. Till the time you get completely of those fundamentals, scientific fundamentals in your mind, okay, you can use it as a memory aid. Those tips and tricks. That's what I would always advise. Okay. So, any questions so far?
So, you know where like left bundle branch block, is that always in